Good evening, everybody. Thank you very much. Thank you for being here tonight. This, just so you know, is our very first program of 2020. Yay, everybody. Thanks for coming. All right. So tonight, we're going to have two different presentations happening. Our first is with Patricia Pagnotta. But Patricia Pagnotta, she's a APRN. She's an MS certified nurse who has been working at Neurology Associates in the MS Center of Greater Orlando since 2005. She's an active member of the MS community and is the current president of the MSCN, a member of the CMSC. By the way, for those that don't know, MSCN is the International Organization of MSRNs, and she's a member of the the Center of MS, I can't remember this, Consortium of the MS Centers. Thank you. I got to start remembering that. She's also clinical advisory committee for the National Multiple Sclerosis Society. She's been a principal investigator in many MS clinical trials and sub-PI in more. Explain PI. She's a principal investigator. There we go. All right. So she's principal investigator in many MS clinical trials and in sub-trials, all right? She's published in peer-reviewed journals and has spoken to peers nationally and internationally. She runs a support group at her practice and very much a patient advocate and speaks for many groups to persons and caregivers of multiple sclerosis. Let's welcome Patricia Pagnotta. Thank you. I'm sorry for that. So after Patricia's talk, or Tricia as she likes to call herself, but after her talk, we're going to do a Q&A. And during Q&A, I'm going to walk around the room. I used to run, but I have a boot on, all right? But I'm going to walk around the room, and I'm going to put the microphone to your face. Please understand, I'm not trying to knock out your teeth.
Okay, so thank you, Stuart, for allowing me to be here and to kick off this new decade. Isn't it so exciting? Anyhow, and I'm extremely excited that Stuart has decided to do these programs in rural America. And, you know, those of us that live out here in rural America, we don't think it's so rural because persons are coming here by droves. But anyhow, so I'm pleased to be here, and I hope that I'm able to give you some good information tonight. Anyhow, so I want to start the talk by introducing what is multiple sclerosis. And many of you may know that multiple sclerosis is an immune-mediated disease. That means your immune system is involved, your immune system gets confused and starts attacking your central nervous system. The central nervous system is an electrical system. And so what happens is the T and B cells, the immune cells, get into your central nervous system, start attacking the myelin. That myelin gets broken down, and from that you get scars, multiple sclerosis. That's how multiple sclerosis got its name. Multiple scars, sclerosis means scars. And so we can see that on MRIs. And so it's very important to know this is what causes your symptoms. Stuart has asked me to talk to you about the new way that we talk about the clinical courses of multiple sclerosis. And so some of you, this is a rather busy slide, but some of you may remember that there used to be 4 different types of multiple sclerosis. Well, we don't have 4 types anymore. We literally have 2, relapsing and progressive. So in relapsing MS, we have clinically isolated syndrome. And it is a little bit harder now to find clinically isolated individuals because the McDonald criteria, which is the criteria that we use to diagnose multiple sclerosis, now in the right setting, with the right history, with the right exclusion, there is time that we can diagnose persons with their very first MRI. So clinically isolated syndrome is not as prevalent as it used to be in the past, but it is still there. And what that means is a person who has lesions, has a history that is consistent with multiple sclerosis, but does not yet meet the McDonald criteria. They basically have had one incidence, and we can't get time, a separation of time. So we know that treating multiple sclerosis early is extremely important, and so that's why this has not been dropped from the criteria. When we look at relapsing forms of multiple sclerosis, then we further divide that into active and non-active, and that's basically how we're going to define both the relapsing and the progressive disease. Either you are active or you're not active. So what does active mean? In relapsing multiple sclerosis, you have to be active to get into a clinical trial. So that means you have to be having relapses, or you have to be having MRI activity. So it is the ability for us to objectively say a person is still having inflammation, the inflammatory part of the disease. If you're relapsing multiple sclerosis and you're not active, that may mean that you're on a really good drug, that you're on a drug that is working really well for you, and so therefore you haven't had any MRI activity for a while, and you haven't had any relapses. So that is still a person who has relapsing, but they're on a really good drug and they're in a really good spot. And so that can happen for a long period of time. But relapsing, although in relapsing, you don't have to leave the category if you don't make a complete recovery from every relapse. But relapsing is not defined by progression of disability. When we look at progressive disease, that's where we start looking at individuals who are having more progression of disability than they are having inflammation. So persons who have primary progressive, they have disability from onset of their disease. And so whether they come in and see us and are telling us about the last 2 years of their life, or we're looking at how they have progressed, it's a person who may have some acute neurologic symptoms, but they don't make recovery from those. They may make some, but not a full recovery, and not to the place that they were even before. So they are progressing with disability. But again, in primary progressive, you can have persons that are active with progression. So persons that we have seen, some persons with primary progressive, we do MRIs on them and they have enhancing lesions. So that's a person who has primary progressive who has active progression. They have signs of inflammation. And then we have persons who are active but without progression. Maybe we're seeing active lesions on the MRI, but they haven't physically, disability-wise, gotten worse. So that is how we would categorize those persons. When we look at secondary progressive is a person who originally had relapsing multiple sclerosis. You can't start at secondary progressive. You know, that's a point you move to. And so that's when your disease is becoming much more disabling than it is inflammatory. And so when you start having more disability, then you have inflammation, acute attacks, and in between having any attacks at all, you're getting a little bit worse. But initially you were having attacks that you recovered from a little bit or completely, and then you stayed stable for a little while and you had, so that is what secondary progressive is. Now, in secondary progressive, we have active and inactive. And some of you that keep up with all of the newer therapies that are approved and whatnot may have heard about active secondary progressive, because the FDA coined that term, active secondary progressive. And so what that is an individual who has moved out of the relapsing phase into a more progressive phase, but is still having acute attacks, either acute relapses that we are sure that are not coming from anything else, and or inflammation seen on MRIs. So that is a person who is active. And persons can have be not active, but getting worse as far as their disability. So again, the two categories are persons who are either relapsing or persons who are progressive, and then you further subdivide out of those categories, are you active or not active? And what does this mean to you? It means something to your healthcare provider. Because it's how your healthcare provider is going to be able to talk about a disease-modifying therapy that they're going to put you on. Or in this day, we are thinking about, should every person be on a disease-modifying therapy for the rest of their life? So there are studies that are being done looking at whether or not persons should be withdrawn from a disease-modifying therapy if, in fact, they have been stable for a long period of time and have no signs of acute progression or active disease. So really, this is what we need. Most of you want to know about that. In my experiences, persons ask me that because they want to know, okay, well, what does this mean for me down the road? And I would like to be able to say, if I diagnosed a person with relapsing multiple sclerosis, where they would be 5 years from now. I don't know. And I have diagnosed persons with primary progressive, which is a very rare group, and have been more stable than some of my relapsing patients. So again, it's very important for you to consider more what is going on with you and how you communicate that with your healthcare provider. This is terminology you'll see in the literature. You'll see this in information about drugs. But for you, in my opinion, it's more important that you can give a good history to your healthcare provider and also keep us informed as things change. So that's very important. So when I talked about active or not active, part of the most important thing is relapses. And this is still something, as long as I've been treating multiple sclerosis and as many patients that have been with me almost as long as I've been practicing, sometimes will come in and tell me, I think I had a relapse. I'm like, well, I didn't get a call from you. And now with the EMR, I go back through my thing. I'm like, did they call and somebody forget to send me it? No. So it still can be very confusing. So it's always important for us to review what is a relapse. And I say that because I want you to be educated. But I go back to the most important thing is that you know you. And if you're changing, it's not your job necessarily to define a relapse. I want you to know what we're going to ask you and talk to you and be educated. But your job is to tell your healthcare provider if something's different. Okay? So might we call it a relapse? Well, it has to be something that changes in your neurologic system. It has to last more than 24 hours. And it has to not be able to be explained by something else. So if you started a new medication, if you, it's a little bit colder up here the last couple days. And so some people love the cold weather. Some persons find that their spasticity is a little bit worse. A little bit worse in the cold weather. And some persons cannot be in the heat, or they melt and they can't get 50 feet. But then there are other persons that can go lay on the beach at Daytona and stay there all day long on a 90-degree day and be just fine getting back to their car. So it depends, but if it's something that is provoked by something else, then it is not a relapse. So your healthcare provider will ask you about, have you started new medicines? Any symptoms of an infection? Have you done anything outside of your normal? And so they'll ask you about that. When we are measuring relapses, we say that you have to be stable for 30 days before we call it a new relapse. And so that's very important for us because as healthcare providers that specialize in MS, we know about the prognostic indicators in persons, how many relapses they have in the first year, how many they have in their first 5 years, and how that portrays to what they might look like down the road. So that's very important for us. But what's important for you as a person who is living with multiple sclerosis is not, okay, well, I got to wait now 30 days. I had a relapse. She told me it was a relapse. Now, if anything happens to me, I have to wait 30 days because she already told me it's a relapse and it takes 30. No. If you are not stabilizing, if you're getting worse, even if you're not getting better, we don't necessarily guarantee that persons will get better from relapses. That's the sad thing about MS. We don't know. We hope that people do. But if you are not stabilizing, getting better, or things are getting worse, you need to talk to your healthcare provider about that to see if there's more therapies that need to be looked at, i.e. physical therapy, occupational therapy, relapse management in the form of either steroids or Athgar or even plasmapheresis. So it's extremely important that you keep your healthcare provider up to date. So it's very important to think about these typical things because, when you call your healthcare provider and you tell them, I have blurring of my vision, and if you don't get right to the person who is the end user of you, i.e. me in my office, and you get to one of my medical assistants, I have very well educated about the fact that persons that have relapses need to come in and see me. They need to be seen, and so you just put them in my schedule. So then it becomes a little funny, for lack of a different descriptor, when the person comes in and they tell me they've only had that blurry vision for like about an hour or so. And I'm like, okay. And then they've paid a copay to see me. And so sometimes that's not pretty. So again, the typical presentation is that neurologic symptoms will evolve over days. Very rarely do they happen suddenly. That's more like stroke. Most of the time things get a little worse over days or hours, and they may plateau at days or weeks and may take weeks to months to get better. So that's a typical relapse. So again, it depends upon the severity, and it depends upon where these lesions are, what your symptoms would be. But this is what most classic relapses, how they present. When we talk about the natural history of multiple sclerosis, so this is going back in time to before 1993. We have not done any natural history data since disease-modifying therapies came out. So natural history data is what happens to persons who don't get treated. And we have a whole group of people that were around before 1993. Because, it really wasn't that long ago. But anyhow, and back then we had these 4 categories. And so it's very important to note that good news is that most persons at time of diagnosis have a relapsing form of multiple sclerosis. Only 15% will have a primary progressive. After 11 to 15 years, persons with relapsing multiple sclerosis that are not treated almost 60% will go on to have secondary progressive. So please don't walk away from here thinking, oh my gosh, I have a 60% chance of being secondary progressive in 11 years. That's only if you're not taking a disease-modifying therapy. So again, this is natural before disease-modifying therapies, what the world dealt us. And so then after that, only 42% still had a relapsing form. So this speaks volumes to our disease-modifying therapies. So now we're moving on to talking about some of the other topics that Stuart wanted me to get into tonight with you. And before we get into those, I really feel like we have to talk about what is comprehensive care. And so this is how the Consortium of Multiple Sclerosis Centers defines comprehensive care. So comprehensive care embraces the philosophy of empowerment in which the person with multiple sclerosis takes an active role in planning and implementing healthcare and self-care activities and acts as a consultant to the team. This is an active rather than a passive role, is fitting in light of the fact that multiple sclerosis, like all chronic illnesses, is expected to last a lifetime. Persons with multiple sclerosis learn to adapt and change in response to alterations in their physical functioning. So that's what comprehensive care is. That's what we who specialize in MS strive to help persons with. And so when we look at how do we help with comprehensive care, many of you may heard this said before, it takes a village to take care of a person who has multiple sclerosis. And that's because one person, even the best healthcare provider, cannot do it all. We need the person, which, and I'm sorry, this patient didn't come up the middle there says patient. And then we need all these different spokes. So at different times, depending upon where you are, you might need a physical therapist, an occupational therapist, a vocational counselor, urologist, speech pathologist, psychologist, neuropsychologist, social worker, your primary care physician. That is extremely important. Everyone should have a primary care physician. So it's very important that we think about that. It does take a village, and a village is a very comprehensive group of persons, but with the patient in the middle, helping us and consulting with us about their care. So when we talk about symptoms of multiple sclerosis, there is a cycle of symptoms, and I'm sorry that the footnote didn't come up here for this. I can provide it. But in this cycle, we know that if things are not dealt with, they can snowball. So if you have bladder problems and those bladder problems are getting worse, that will potentially cause you not to be able to sleep as well because you're going to be up and down to and from the bathroom. If you're having cognitive functions and that is not taken care of, then you might have difficulty sleeping, you might have increased depression or fatigue. Exercise, if you're not exercising, might your spasticity get worse and might your fatigue get worse. So this cycle, if you think of, the rat on the wheel or the hamster or even a bunny rabbit, I think, plays on wheels. But if you think about that, if you don't do something, then you're going to be running around taking care of symptoms that might potentially be getting worse. So if you take nothing else from today, think about, for 2020, what do you have that's on this slide here? Do you have fatigue? How might you improve fatigue? Well, there's a couple ways that it can go. So think about a very holistic way of helping us help you. So when we look at holistic care and taking care of individuals, there are therapy options that we have. And there is what we call standard medical care. I'd like to standard provider care because nurse practitioners do this too. So this is where a licensed healthcare provider with a degree that specializes is going to prescribe therapies based off of what we call Western medicine or scientific evidence that we have that something will affect something else. So the scientific evidence we have in multiple sclerosis is the evidence we have for all of the disease-modifying therapies. Is a good example of what Western or standard medical care would be. That person should be diagnosed accurately, quickly, offered a disease-modifying therapy, and be monitored appropriately based off of that disease-modifying therapy. Up here next, you see complementary medicine. And I purposefully have separated out complementary medicine and alternative medicine, despite the fact that when you're reading literature, you'll oftentimes see what it says here under integrative medicine, CAM, because many of the literature will put those complementary and alternative into one bucket. I see them as very, very different. So complementary medicine is treatments that are used along with standard medical care, but they're not considered standard treatments, but they are used in conjunction to help individuals. And so an example of this might be something like acupuncture. So that is complementing what you are already doing. Exercise is an excellent example for complementary medicine. When we look at alternative medicine, though, that's different. Alternative is doing something instead of what is considered standard medical care. And so these are persons that will come in and I diagnose them, and they have read about all of the maybe side effects, and they've read about some things that could happen, and this is a lifelong disease, and I'm just going to live my life the best I can, and I'm not going to go through any of that, and I believe that this, that, and the other will be helpful to me and actually will cure me because it has for somebody else I know. That would be considered alternative medicine, where a person is going to do something instead of what has been proven to be effective. So that's alternative medicine. So doing a special diet versus going on a disease-modifying therapy is an example of that. Now, integrative medicine is a combination of both standard medical care and complementary medicine. It says up here CAM because, again, the integrative medicine article that I pulled this from describes it as CAM, but I think that alternative medicine is not where most integrative medicine individuals are. So this is using both standard medical care and complementary care, but the focus is looking at the patient's mind, body, and spirit. So many persons call this functional medicine, where persons are very professional at integrating diet and different other therapies, the acupuncture and some of the other complementary that we're going to talk about in addition to, and getting into meditation and looking at how your mind controls your body. So that is very exciting. So when we talk about complementary medicine, it's very important to keep in mind a few things. just like you would if I was going to prescribe some standard medical care for you. If I was going to prescribe a drug for you, you would be asking me, well, what does this treatment involve? What do I have to do? How does it work? How's it supposed to work? How effective is it? And what are the risks associated with that? And then how much is it going to cost me? Is my insurance going to pay for it? And then will it interact with other things that I'm doing, other therapies that I'm on, other diseases I might have? So that's something that should be a roadmap for making decisions with just about everything with healthcare. But when you're talking about complementary medicine, you really need to make sure that the same questions you asked your healthcare provider about the standard medical care, you are also asking about complementary medicine. So when we look at the guidelines from the American Academy of Neurology, and again, the American Academy uses the clump there of CAM, their guidelines for us are do CAM therapies reduce specific symptoms and prevent relapses or disability? That's one thing that should be considered. Can a CAM use worsen multiple sclerosis or cause serious adverse events? Can CAM therapy interfere with disease-modifying therapies? And so these are the very first three questions that the American Academy of Neurology looks at when they're making recommendations about some of these complementary therapies. And I put this last bullet here because it was all through the guidelines for those of us who are healthcare providers, that although these are very important questions, they have not yet been sufficiently answered, that there are not enough studies to be able to answer many of these questions. So when we're looking at some of the things that persons are eager to try, I don't necessarily have the data that persons would ask me about when they're asking me about a disease-modifying therapy. So the first is cannaboids, and we're not going to go through every single complementary medicine. I've picked out a few because, Stuart, I have a limited amount of time. And so cannaboids are drugs that are plant-based, and they are either THC or CBD. So cannaboids is the bigger umbrella, and then you can break it down into whether you're getting THC or CBD. What persons espouse that these drugs do is that they improve pain, spasticity, bladder incontinence, and number of voids and tremor. In quotation, I have up here that there's no objective improvements that we have seen. There is not yet a clinical study that I am able to tell you that when we test persons who have taken any form of a cannaboid on the Ashworth spasticity scale, what would be required of me to be able to prescribe or have baclofen. Let's say that's a drug for spasticity. For the FDA to approve that for spasticity, I would have to be able to prove on an objective test that it improves spasticity. I don't have that with any of the cannaboids, okay? But there is many reports of individuals who say subjectively, my pain is better, my spasticity is better, my bladder is more relaxed, I don't go to the bathroom as frequently, I don't have incontinence, and my tremor is much better. So although I don't have objective evidence, and there's a lot of other things that people think that cannaboids do, but this is what we have study-wise. And in all of these areas, the reason I included these possible benefits up here is because these are the areas that significant amount of persons has subjectively said that they find improvement. So then you have to go back to, okay, what might this do for me? And this is what it might do for you. Then we have to talk about, well, what might be the side effects? Well, dizziness, somnolence, memory disturbance, difficulty concentrating, increased appetite, nausea, vomiting, constipation, dry mouth, temporary psychosis, and I have to say that is more common with THC, although it has been reported with CBD. Hallucinations, again, more common with THC, rarely with CBD. Balance difficulties, and increased risk of heart attack. So those are the things that we know potentially could be side effects. And so then you have to think about, okay, well, am I willing to take that potential? Will it interfere with your disease-modifying therapy? Well, cannabinoids are metabolized by your liver. So many of the disease-modifying therapies that we give persons also are metabolized in the liver. And we have to monitor liver enzymes. And so there is a potential that your liver enzymes could be elevated. So if you are doing this, you need to make sure that your healthcare provider knows if your liver enzymes go up. Other than that, with the specific disease-modifying therapies, there is not a drug-to-drug interaction, but there are over 100 other drugs that there are drug-to-drug interactions. So if you have anything other than MS, make sure that you talk to your other healthcare providers about the potential drug-to-drug interactions. And now I believe that most of the pharmacists in commercial pharmacies can answer that question for you too. Ginkgo biloba is something that persons frequently ask me about. Possible benefits, persons have talked about improved cognition and improved fatigue. There have been no objective evidence for the improved cognition. There has been objective evidence for improved fatigue. So there is a chance that for some persons you might get improved fatigue. When we look at the side effects, generally it's pretty well tolerated. Most persons don't have any difficulty with ginkgo biloba, but if you have clotting difficulties or you're on a blood thinner, that's a very serious no-no. So you should talk to your healthcare provider. It may increase the risk of seizures. So if you're on other medications that may increase that risk, or if you've ever had a seizure before, you need to be very careful. In animal studies where we've used ginkgo biloba at what would be high dose for that animal, but would be the typical dose that we would give a human, and this is oftentimes what we do. We give animals a lot more than, but it's the dose we would give a human, but a lot more than that animal should be getting. We did see an increased risk of liver and thyroid cancer. So that's another thing to consider. There has been no established interference with disease-modifying therapies. But there also has been no effect. They have tried studying ginkgo biloba for treating relapses. There has been no effect that ginkgo biloba will help improve a person's recovery from a relapse. Reflexology is manual pressure applied to points in the feet, and possibly this could help with paresthesias of the feet. There's inadequate data to prove that it affects pain, depression, anxiety, fatigue, disability, cognitive function, bowel or bladder function, although persons have described that, but there's insufficient data. Usually this is very well tolerated and very few people have side effects from reflexology, and it does not interfere with a disease-modifying therapy. So this would be something, the risk of doing this is very low. The potential benefit's pretty high, so I might try that. Magnet therapy. This is a big thing that persons are talking about now. And these are these bioelectric magnetic mats. And they come in long mats that you can lay your whole body on, or you can get them smaller than that. It depends upon how much of an investment that you want to make. So these can be very expensive. They can be up to $10,000 depending upon the kind that you're getting. But the possible benefits, persons have talked about improved cognition, fatigue, disability, bladder control, depression, sensation, vision, and mobility. We have not seen any of that proven objectively, but persons have talked about that. The reported side effects, headaches can be very common with this. And some persons have increase in their spasms, and some persons actually complain of a burning sensation from laying on the mat. And and there's no interference with your disease-modifying therapy. So the biggest thing I think with this one, depending upon how gung-ho you're going, they have magnetic socks, they have all kinds of magnetic things. But if you're going for the Mac Daddy mat, that's a pretty expensive piece of equipment. So complementary also, we look at diets. And I want to preface this with, we're talking about diets and the effect on the progression of multiple sclerosis. So we're talking about the ability to reduce relapses, the ability to improve or stop disability, and MRI activity. So we have seen no objective improvements with diets. Although persons have talked about improved cognition, fatigue, disability, bladder control, depression, sensation, vision, mobility, reduced relapses, and decreased MRI activity. Now, from a person that many of you may know, I am a vegan. He pointed that out, that I would have had this blue thing here. I can tell you, persons that are healthy do better with MS. So I would debunk many of these things saying, if you're healthy, you're probably not going to be as depressed. You're probably going to be more active. You're probably going to be more engaged in your community, so maybe you will have better cognition. But a direct correlation, can we say that the diet did this and nothing else? So that's what I'm talking about here. We do know that tobacco and alcohol are extremely harmful. Tobacco will increase your risk of secondary progression to secondary progressive 50% faster. We know that alcohol is a toxin to the brain and will increase your brain atrophy. In addition to that, puts you at very high risk for falls and other injuries. So those two things we know should not be in your consumption. We know proven supplements, vitamin D, if you have other vitamin deficiencies. So vitamin B12 is a very good thing, but if you don't have a vitamin B12 deficiency, taking vitamin B12 might not necessarily be anything for you. When we look at the healthy diets that have been studied to be healthy, not just in MS, low carb, whole food diet, Mediterranean diet, the paleo diet, vegan, and gluten-free. So those are the things, if you wanted to try a diet to help you feel better, then these would be the diets that I would tell you have data around that and will help you with other medical conditions also. So when we look at other complementary therapies, it's very important, as I've said, exercise is a complementary therapy. And we do know there have been studies, several studies that have proven that exercise does improve fatigue. So every time somebody comes in my office and tells me how tired they are, and I ask them how much they're exercising, and I get that look, I'm like, yes, exercise will improve fatigue. It will reduce your fall risk. It will improve bowel and bladder function. It improves strength. And we know in studies outside of MS, in degenerative disease like Alzheimer's, that exercise will affect the brain atrophy. So we can't say that for MS, but we know that in other chronic neurologic conditions. We do know that stress management is extremely important and helps persons cope better. And we do know that stress increases your immune system. And so we do think that there is correlation between stress and relapses. Acupuncture, we know, reduces pain for many persons, improves bladder control, and can help with smoking cessation, alcohol cessation, or obesity. Persons are using acupuncture for. Okay, so access to care and specialist. This is a really, really hard topic. So access to care, you should be able to find specialists through the American Academy of Neurology. The International Organization of Multiple Sclerosis Nurses can help you. The National MS Society has a navigator program that will specifically help you with anything that you need. Through the Consortium of Multiple Sclerosis Centers, you can get a list of centers in the United States, and all of those centers meet the criteria for a comprehensive center. Stuarts MS Views and News has plenty resources on his page, the MS Association of America and MS Foundation. When we look at, again, all your health needs, Naomi, the National Alliance for Mental Illness, is also very helpful for persons who are having problems with their mental illness. So you don't have to have schizophrenia or one of those really bad things. You can have a mild depression and they can be helpful. They can help you find someone to help you. If you want to know how you can get affordable care, free care is clinical trials. So you could go to clinicaltrials.gov and see if there's a research study that's being done in your area. You always want to talk to your primary care provider because they probably know somebody. And they might be able to make recommendations for you. Obviously, you want to consult with your insurance company because your insurance company's got to pay the bill. If your insurance company does not have a neurologist in your area, then you can appeal to your insurance company that you have to pay for somebody outside my area because I have to be able to see someone who can take care of my disease. And so if it's not in my area and you don't have one, then you can appeal to them to pay for someone who you might go to. Local health departments have care and can help you access affordable care, and even local hospital systems can help you with that. Accessing care, part of what I think is the ability to access your disease-modifying therapy. So all of these are the disease-modifying therapies that we currently have, with the exception of Ampera and Athgar. Athgar is used to treat relapses. Ampera is used to treat walking problems. But any of these entities have support on their websites for how to get their medications. In addition to that, they have support on how to and things to learn about multiple sclerosis. So I would encourage you to look at those. When we look at online, I think everybody in this room could probably give me an education on online because there isn't very few patients that don't come into my office and tell me about something they've read online. And they find some of the most interesting things. And so I try to point persons to reputable sites. So one of the best sites, not because I am the president, but one of the best sites I know of is LiveWiseMS. So LiveWiseMS is a website that is sponsored by the International Organization of Multiple Sclerosis Nurses. What we do is we put articles that I would read as a medical professional on there. We digest that article for you, so we give you a synopsis and the important things about that, and then you can also access the whole article. So you can get videos, graphics, everything that I would get, you can get. You can search by topics. You can go into the community section and look for persons that might be having similar symptoms as you. And very importantly, and not enough people take advantage of this, but we do have a blog, and this is not a blog for you to get on and complain about X, Y, or Z. This is a blog for you to get on and ask a non-specific. You can't tell me, my name is Jane, and I am 45 years old, and I've had MS for 7 years. What drug do you think I should be on? But you can ask us a question about something that you want to know, and we will answer that question for you. So it's important. If we can't answer that question, we're going to let you know that too. So it's your access to free MS experts. When we look at other online, Stuart was trying to tell you earlier how to get to his resources. Here's a picture of it. So this is his home page. You go up under information and you go down, and then it's got all the medications, pharmaceutical, patient resources, or he's got everything under the sun and then some listed there. And the good thing about that is you just go to one of those and you click on it and it takes you right to the website. Okay? So again, that's very important. And then this other one that I like is MS Teamworks. Has anybody seen a TED Talk? They're very popular. And so these are TED Talks, so to speak, about MS. They're of persons who have the disease, persons who treat the disease, persons who know somebody, a caregiver. So it's all formulated TED Talks. So you could go on to MS Teamworks and listen to any of the TED Talks. Just like with the MS Views and News, you can go on to their YouTube channel and see this again a month from now, I guess, maybe. So that's important. Here are other good resources. NARCOMS, the MS Coalition, MS Society of America, the National MS Society, MS Views and News, MS Foundation, NIH, and the Paralyzed Veterans of America. So keep in mind, as I tell persons, you are not on a sprint. This is a lifelong condition. You are on the race of your life, so please make it the best that you can be. So now I'm open for questions. And I can run around with this. No, he doesn't want me to run around because I have to stand here because the camera's on me. Yes.
You mentioned when you were talking about the cannabinoids, why would there be an increase of heart attack from cannabinoids?
Aha. So her question is, why would be there an increased risk of heart attack with cannabinoids? Because not all persons are calmed by cannabinoids. Some people are agitated. Some people get paranoid. Some people have cardiac arrhythmias because of the electrical changes that occur. So that is something that we have seen documented in the literature. That's not just might do it. We have seen an increased risk of that. And it's young persons that come into emergency rooms that come in with weird things. They all get drug screens. And, I had this cute little lady in my office last week, 70-some-odd years old, and she said to me that she went to an emergency room and she can't believe they came back and told her she had THC in her urine. I'd only had one gummy in my life, and it was 3 weeks before. I'm like, honey, it stays in your system for maybe 6 weeks. So.
Anybody have a question? Great. Good. Thank you. 1 minute. Please wait till I bring the microphone to you, and please know I'm not running.
How do you know if you have the relapsing or the secondary progressive? Because I have active lesions, but I'm seeing a new neurologist.
Okay, so when you talk about active lesions, if you're talking about enhancing lesions, if you're a person that still has enhancing lesions, you still have inflammation and you still have a relapsing form unless you are one of those rare individuals that has primary progressive and has an enhancing lesion. That is exceptionally rare. But it can happen. So most persons with primary progressive know they've got primary progressive after a couple years because they're just continually getting worse. They're not having any relief from their disability getting worse. So I would say that probably you have relapsing.
There was an awful lot of negative things written up there about the cannabinoids and the safety panel and so on. But compared to other meds that people are using instead of, such as benzodiazepines or anything for pain, anti-inflammation, that type of stuff, Advil, acetaminophen, how does that compare to those? Because I don't know of any deaths caused by cannabinoids, but I know that Advil and stuff has damage to the organs and has resulted in many deaths. What do you feel about that?
Well, I think there have been deaths related to cannaboids. And I think that many of the vaping stories that we've seen published or talked about recently, I think that because it hasn't been legal and because it's not a prescribed therapy, that's why you don't see as many things attributed to that. So I think that the data is yet to become on potentially that, but it does go through your liver, and so you could have liver issues. Again, I think that what holds me back from being able to put a good housekeeping stamp of approval is the fact that I don't have enough data. And despite the fact that I am very much a promoter of comprehensive care and want persons to do complementary things and want persons to live their best life, I don't have the scientific data yet that I can answer those questions. But yet, the other side of the coin is I want persons to look at that as objectively as they would the Tylenol, the antihistamines, and the anti-inflammatory medicines as they affect your cardiac status. So I think that if persons are looking at that rigorously, then they'll make the best decision and they'll try it out with an open eye. Okay, well, I'm going to try this because maybe the risk isn't so bad and I'm going to try it. And if it doesn't work for me, it doesn't work for me. But I'm not going to keep taking it because. So I think that, again, everyone has to do their own little clinical study until we have more data.
Right. Any other questions? Everybody knows everything? I didn't think so. So your arm should be up.
Hi again. You mentioned something about now that you have EMRs. What is that?
Electronic medical records.
Okay.
So that's where we have to, and as of this year, those of us, as we refill our licenses, we cannot write prescriptions. It's all got to be electronic. And by 2021, there will be no more written prescriptions. They all have to be electronic. So anyhow, that's an electronic medical record. It has done wonderful things for some and has been a wonderful tool, especially from my view, a patient who utilizes that tool to its maximum can get in and out of their chart, can look at things that occurred during their visit, can check up if we mistyped or we talked about something a long time and then it didn't wind up in the note, or they can send messages back and forth. I mean, I don't know of anyone who likes calling a healthcare provider's office, but sending a little text off of your smart whatever device you have is much easier for many people.
Anybody else?
I have a question. What do you think about weaning yourself off of a medication like Copaxone? I've been on since January of 2000.
Okay, so that's one of the things that we are now looking at as far as the DISCO study is one of the biggest studies looking at persons who are on disease-modifying therapies and have been stable for a very long period of time, have no recent activity, no disability changes, no relapses, and no MRI changes. And they're looking at that anywhere from 2 to 5 years. And then through the DISCO study, they're doing it the best way, I think, is because if you're a person that goes into that study, you meet that criteria, and you're, say, on Copaxone, then you're going to be taking an injection, whatever you're doing now. If you're doing the 3 times a week, you're going to be taking an injection 3 times a week, and you won't know whether you're giving yourself Copaxone or if you're giving yourself a placebo. Because when persons affect, your mind affects. So we will really know out of a study like that, is it appropriate to take persons off? You asked me, the first question though you asked me was weaning. I don't think there's such a thing as weaning. We know what drugs do at the dose that we tested them in. So if you take them any less, then you're going to get less effect. You don't need to wean off of disease-modifying therapies. You just stop taking them as they're prescribed, and they'll become less effective. There's no disease-modifying therapy if you stop taking it, with the exception of Gilenya, that you're going to have some terrible anaphylactic or withdrawal type of symptom. We do know, documented in the literature, that persons who withdraw from Gilenya suddenly and do nothing different, that there have been a number of persons that have had significant rebound disease. So that's something that...
So in the past, a lot of times when a person was taken off a medication and put onto something else, they were told there's got to be a burnout period or a dry out period first. And this is, I think, what's on the mind of many people these days, is they're afraid to come off because they've heard about this rebound effect. And, you know, what's being done now with the medications? Are they just being switched from one to another, or is there still that dry out period?
So again, depending upon who you're seeing, the specialist you're seeing, if you're seeing someone who treats MS and that's what they do, they recognize most of the time the risk of washing someone out, meaning waiting for that drug to completely be out of their system before they put them on another therapy. Because any person that is a period of time off of therapy, you're playing Russian roulette with, might you possibly have some activity while you're off. We know that the higher efficacy therapies that stop people's MS in their tracks, that the coming off of them abruptly might be more likely for persons to have that fulminant back to where they were. We've seen that sometimes also with Tysabri, but it hasn't quite gotten the black box warning that Gilenya got. So most of the time now, I'm looking at the mechanism of action of the drug, and if it's particularly a high-risk situation, let's say we're talking about two drugs that can cause that very bad disease called PML that sometimes can be deadly. So if we're talking about something like that, then if I'm going to not wash out, and so conceivably for a period of time I have persons on two drugs, well, right before we switch from one to another, we're doing an MRI. And depending upon how that MRI does, we might even be doing a spinal tap. And I know of some of my peers that say everybody that goes from one drug to another, depending upon the risk of PML, they might get a spinal tap anyway, just to be clear that they're not going to pass that on to another therapy. But I think it's reasonable in many situations that there is not a washout period. When we're talking about the self-injecting medications, there's no reason for a washout period of those drugs unless you're having some type of lab abnormality that would be affect the next drug. But from a mechanism of action of the drug, there's no need for a washout. Does that answer the question?
Okay. You have a question?
And you mentioned the importance of having your primary, your neurologist, and your specialist, okay? But sometimes when we have relapses, what we, as many years with MS, recognize what is relapse. I don't know which doctor go first. For example, optic neuritis is one of my main problems. Because if I go to my neurologist, it's going to send me probably to a neuro-ophthalmologist or any other specialist. So I don't want to be jumping specialists. So my question will be like, where maybe we start first?
Very good question. Because I know some persons that say similar thing with, well, my primary care thinks everything is MS. So they want me to call you first. Everything is MS. And so when you're having a neurologic symptom, when you're having a symptom that could be coming from your neurologic system, then you should call your neurologist, your neurology team. So your nurse practitioner, your neurologist, your neurology office. You should call them first. They will do the punting as to whether or not you need to see someone else. An acute optic neuritis does not need to be seen by a neuro-ophthalmologist. It can be diagnosed and treated by a neurology team, but yes, over time they may want you to follow with a neuro-ophthalmologist to see the recovery and whatnot. Many persons get to neuro-ophthalmologists as a part of the diagnosis. But if you are having an infection, let's say you have an upper respiratory tract infection, and you know you've got an upper respiratory tract infection. You're coughing, you're hacking, you've got fevers. And on top of that, well, I'm a little more fatigued and my spasticity is worse. Don't call your neurology team first and say, well, I've got more spasticity and I've got a little bit more fatigue. And then, start telling us about all these other things. Go get the infection treated by your primary, and when your primary is doing that, then call your neurology team to have maybe supplemental therapies given for those symptoms until you get better. But the cause of those symptoms is the infection, so you need to fix the infection. So if you don't know, when in doubt, if it's a neurologic symptom, yes, call your neurology team. We're real good at punting things, but it's important that you don't expect your neurology team to be able to provide all your standard medical care. Like, I don't know at the top of my head, without having to look it up, what are the vaccine schedules? I don't know at what age that person should start having all these different cancer screenings done. Yes, I can look it all up, but that's not what I do every single day. I want to be able to work on what I do best and leave that other for someone else.
Any other questions?
One other thing, I still think the copay to see me is a little bit higher than it is to see your primary. So if it can be taken care of, and it's not a neurologic thing, even though maybe I could treat a urinary tract infection, it's cheaper to go be seen by your primary. Okay, well that's that. There you go. Then get a different primary.
Mine has to do with a UTI that has been going on since the end of July. I have been on multiple antibiotics to try and take care of this. I went to my primary about 3 weeks ago. His response was, "You will always have bacteria there now." And I'm like, I did not accept that. And they just, when they did the blood work and did the urine sample and all that, my blood work came out fine. And the urine sample didn't show anything, but every time that the urologist sent the urine sample away for a culture, it shows up. And I know that I still have a UTI. What would, they've been treating it, but how do I get to a point where it's gone?
Okay, so
I know it's not a neurologist.
That's a complicated question, and we're gonna step back and forget that you told me this is you, because I cannot, I'm not here to give you medical advice. But I actually did a study. I was a primary investigator on asymptomatic urinary tract infections in multiple sclerosis. It's published. You could look for it. But there are individuals who will culture positive all of the time because they have developed a organism that they will never get rid of. So that lives dormant in your urinary tract. That is not a UTI. If it's been proven to be one that is, you have become a liking to, and is always going to. Yeah, it's found a home with you. But what happens is when you start having symptoms. So urinary tract infections are not just the fact that you see protein, bacteria, and leukocytes in your urine. Urinary tract infections are symptoms. They're urgency, their pain on urinating, their cognitive difficulties, their increased fatigue. If you truly are totally asymptomatic and you happen to have bacteria in your urine, the urologist and the infection disease doctors tell us that we will do more harm for a person by continuing to treat a colonized bacteria than allowing that colony to be alone and be by itself, because it truly is not a problem. The issue is, though, you have to make sure that that there's a colony, and so a urologist and an infectious disease doctor should be able to determine whether or not you have colonized and whether or not that is something that's going to be your norm.
Thank you.
Mm-hmm.
Yeah, my primary did look at it that way.
Other questions?
Any other questions?
Several years ago, I was told that in your 50s, you kind of plateau where your MS is. Is that true, or is that just something to make you happy and think, no, really, like if you're kind of
No,
okay?
yes. You know, I remember back when I was, a young nurse. Somebody told me, well, you get to 50, you take them all off disease-modifying therapies, And, I was young then. 50 was old. It's not so old now. It's not old at all now. And not only that, the majority of persons are diagnosed between the age of 20 and 40. But I diagnosed just a person last week that was 56. So it's not an age, it's a state of your immune system. If your immune system is still able to cause the attack of your central nervous system, then you should be able to stay on a disease-modifying therapy. So what we are looking at is, we know as we age, our immune systems become less strong for a way, we call it immunosenescence, where our immune systems are not as powerful. If you think about anyone who has had children, it's very easy for a toddler or an infant to get a fever of 103. It's very hard for a 70-year-old to get a fever of 103. So we know our body's ability to become inflamed changes as we age. But we also know that this is an immune system that's confused. And we also know as we age, our immune system sometimes gets confused. That's why you can get things like cancers and other things. So we really have to judge where persons are and are they still active? If they're still active, they deserve to be on a disease-modifying therapy. Now, if you've not been active for 5 years and you're on a really good therapy, is that because you're on a really good therapy? Well, it probably is because you're on a really good therapy. And then you have to think about, well, what is the risk of coming off of that therapy? And so the persons that advocated and told me about that when I was very young were all thinking about economics. And this is something that, will come up again and again as we, every year. Economics. Should you rationalize healthcare? And when you rationalize healthcare, not everybody can have something. So you give, treat the majority of things, and as things start, you stop, okay, I stopped treating this, I stopped treating this. Because it's, if you went to some socialized medicine places, they don't treat this and they don't treat that. They do this. And, if you have a tooth infection, they take your tooth out. They don't try to treat that. They take your tooth out. So that's part of where we need to see where persons are. I do think that there is a time in persons' lives that we really have to look at, do we give persons the strongest medications that we have? We need to be cautious in knowing that persons' immune systems may not recover the way the persons in the clinical studies. Most of our clinical studies max out at 55. And so we don't know how a 70-year-old is going to respond after we deplete all their cells or part of their cells. So that is something that we need to consider. But every person is individual, and if you have something to lose, I personally wouldn't want to stop a therapy, and I don't stop therapies in individuals. I just haven't found a way to wrap my arms around that.
We have to say thank you to you. Everybody say thank you to Patricia Pagnotta.